Good afternoon, everyone. Hope everyone's having a good Saturday. Thank you for joining us on what should be an insightful webinar. I'm Zafar Syed, I'm at Seronis, and I'll be moderating today's session, which is titled Bleeding Happens, Complications Don't Have to, Bleed Avoidance Strategies for Femoral Access Procedures, an Introduction to the Early Bird Bleed Monitoring System. The objective of today's session is to introduce the concept of early bleed detection and how the technology, specifically the Early Bird Bleed Monitoring System, can be integrated into clinical workflow to hopefully facilitate procedures safely and to potentially minimize bleeding complications. Before I begin with the introductions of the speakers and the agendas, I would like to let you all get familiarized with the system and let you know that attendees can submit questions during the webinar. Simply scroll down the page to type and submit the question, and we'll try to get to as many as we can at the end of the webinar. So let's go ahead and begin. Our first speaker is going to be Dr. Mehdi Razavi. Dr. Razavi serves as the Director of Electrophysiology and Clinical Research Innovations at the Texas Heart Institute here in Houston, Texas. He also has appointments as an Associate Professor of Medicine at Baylor College of Medicine and is also an adjunct faculty at Rice University. Dr. Razavi is also the founder of Seronis and the inventor of the Early Bird technology, and he'll review an Early Bird 101, the science and clinical impetus for bioimpedance as a surrogate for endovascular bleed monitoring. We'll also go over the system itself. Our next speaker is Dr. Philippe Genero. Dr. Genero is an interventional cardiologist focused on structural heart disease and complex coronary interventions. Dr. Genero is the director of the structural heart program at the Gagnon Cardiovascular Institute at Morristown Medical Center in New Jersey. And Dr. Genero will present case series on the initial case experience of the Early Bird in high-risk patients. He'll also provide some learnings that he's had in his initial cases and uses with the device in order to incorporate early bleed detection in these high-risk patient populations. And then finally, Dr. Bart Moos is an internationally renowned vascular surgeon with more than 15 years of experience focused on vascular and endovascular surgery. Dr. Moos is based out of Middletown, Connecticut, and is a partner with the Vascular Experts, the largest vascular surgery practice in the country. Dr. Moos would also present some initial cases and provide his perspective as a surgeon on the potential utility and impact of early bleed detection with complex endovascular procedures. So let me go ahead and begin and introduce Dr. Razavi and get him started with his webinar.
Thank you, Zafar. Just as by way of introduction, I want to just take a minute and go over how came up with this concept. Back in the day before the DOACs, the novel anticoagulants had come out, we would often, I'm an electrophysiologist by trade, and we would often cover the patient's post-atrial fibrillation ablation with anticoagulation using Lovenox. And so what happened is on a few occasions we had some significant bleeds with the Lovenox. And the thought came to my mind, it would be really good if we had a means of detecting a bleed at the site as close as possible to the site. So the thought came to me that, we have a sheath there. This sheath could be the probe. It's not being used as a sheath, but it is used as a probe to detect bleeds. And essentially that's what this technology is. It is a means of detecting a bleed using the sheath as a target to get to the site of the problem. So with that background in mind, I'll start my presentation. Next slide. So we all know that bleeding is complications occur. That's just a fact. And when they occur, they increase the rate of mortality, they increase cost, and they increase hospital stays. These complications, unfortunately, occur more frequently than we would frequently like to admit. Next slide. So even though the bleeding is frequent, and a study looking at 17,000 large bore transcatheter interventions from the National Inpatient Sample Database What was found was that the incidence of procedural bleeding is anywhere from 13% to as high as 30% in these patients. Next slide. Not only is the incidence associated with morbidity and mortality, it's also a significant expense to the system. On the average, each event can incur an additional $18,000 to the hospitalization and cost of the patient's care. Next slide. The total cost to the system, assuming an 18% complication rate and 450,000 procedures, approximates $1.5 billion per year. Next slide. And it's not simply these large bore procedures that most of us think about when we think about bleeding complications, such as the mechanical support, impellers, TAVRs, EVARs. Even PCIs, the risk of bleeding is real, and when it happens, there is a long-term increased risk in mortality. Transfusion in and of itself can also portend poor prognosis for these patients. Up to about 80% of patients who undergo PCI can have a significant hemoglobin drop. Next slide. The current paradigm, unfortunately, because the clinical manifestation of these bleeds is somewhat delayed, there is a delay in diagnosing these bleeds. And we rely on symptomology, which is obviously can occur hours later after the patient has left the cath lab. The patient is sedated, they're not aware, they're laying on their back. The sheaths are still in place, but then you pull the sheath and you take them to the recovery area, and that actually can be associated with some of the highest risk periods for having these bleeds. And a single site of cardiac catheterization patients, about 40% of retroperitoneal bleeds presented with hemorrhagic shocks. Next slide. So the early bleed monitoring system, what is it? The system uses a sheath, but beyond that, it uses impedance technology. This is something that's we're very familiar with in the EP field. Bioimpedance is essentially the resistance to electrical current in biological systems. The sheath is essentially the same standard sheath that we're all used to using with a wire dilator system. The only changes are there's 4 ring electrodes on the outer surface of the sheath. These electrodes are emitting a continuous electrical current. On the hub of the sheath and on the flush board of the sheath, you have the user interface display. That user interface is in real time calculating the impedance, the resistance, if you will, to current and that is emitted from the electrodes on the outer surface of the sheath. With bleeding, the impedance drops. Blood is a very good conductor of electricity, and as a bleed initiates and propagates, what we have found is that the level of resistance to electrical current starts dropping, and this is correlated quite nicely with the amount of blood in the perivascular space. And the user interface display monitors that and alerts the physician in a series of 3 lights as the process is propagating. Next slide. And so here's a schematic of the system. The system is placed in a venous in the veins adjacent to the arterial sheath, and as a bleed initiates, the impedance starts dropping, and there's a correlation again with the bleed volume. As you can see, as the bleed volume propagates, the impedance drops more and more. Next slide. The correlation again here can be seen very nicely. This was data that was used to get the FDA de novo granted on March 1st, 2019. You see this is an animal model as there's a progression of the bleed. The impedance is dropping, and the alerts, the red light alerts, which I bring your attention to, are progressing accordingly, thus telling the physician not only that there's a bleed, but whether or not that bleed is progressing in response to any potential interventions. Next slide. The post-procedural aspect of this technology is very unique. Leaving that venous sheath in place after you pull out the arterial sheath, obviously the risk at that point can be the highest because the sheath has potentially been tamponading any access sites for introduction of blood into the soft tissues. It is after that period, after the sheath pull, that the patients actually have the highest risk. And so by leaving this venous sheath in for a couple of hours after the procedure is done in the holding area, this basically is a very precise means of post-procedural monitoring for the onset and progression of bleeding. Next slide.
That's it.
Thank you.
Thank you, Dr. Razavi. I will now hand it over to Dr. Jeanneret to talk about his initial case experience.
Okay. So thanks, Zafar, and thanks, Mehdi, for this great introduction. So what I'm going to try to do in the next 10-15 minutes is to present the early experience with the early bird, so the first number of cases that we did. Next slide. So I'm an interventional cardiologist. I do a lot of TAVR and complex PCI and Impella. So this is the first early bird, first in human study. So this is the study that we did, a single arm. We did 60 consecutive cases. And the goal was really to evaluate the safety and the accuracy of the Theranos early bird system in a variety of procedure, going from TAVR, Impella, but also PCI and endovascular procedure. The primary endpoint was the level of agreement of bleeding detection between the Theranos device, the early bird, and post-procedural CT. So all the patients, all the 60 patients I'm going to present, had a CT before and after to detect new bleed, and we saw the level of agreement with a kappa statistic between the CT and the early bird detection. Next slide. So it was done in 5 centers. You can see the center on the slide. Next slide. 5 co-PI. I was very honored to work with very smart and nice people, as you can see. Obviously, the sponsor was Theranos, and we were held by Proxima and Medical Metrics, who was actually an independent CT core lab who assessed the primary endpoint. Next slide. So this is the flow of the study. So each patient had a planned endovascular procedure. They were consent before the procedure. We had a procedure CT before. It was optional with or without contrast. We performed the endovascular. In this regard, you could use the Theranos in the vein or the artery, and each procedure can be done as a standard of care. Post-procedure, we monitor the patient up to 12 hours or up to prior the early bird removal, and we perform a CT scan within 12 hours of the procedure with the early bird in place to assess the bleeding. Then we remove the Theranos early bird and we send all the data for analysis. Next slide. So this is the study was done pretty quickly, approximately 4 months. We start with 69 patients and we end up with 60 that had appropriate CT scan assessment. Next slide. So this is the breakdown of the procedure. So TAVR 40% with self-expendable, 27% balloon expendable, PCI in 13%, and Impella device in 8%. We also had 1 EVAR and 1 MitraClip and 1 actually SAPIEN 3 in MAC. So a broad spectrum of procedures. Next slide. So the early bird come in a 6 French or 8 French. You can see we use half and half, 6 French and 8 French. And this is the access site, the index procedure, where approximately 16 to 18 French sheet, 14 French and 16 French sheet. But we had a vast variety of French from 6 to 24. Next slide. So most of the early bird were in the right femoral vein, some were in the left vein. Again, we can use the early bird in any vessel, artery or vein. In this study, it was used mainly in the vein to assist next to the large sheet that was in the artery. And you see the breakdown of the sheet in the index procedure, the femoral artery, 78%, left femoral artery, 18%. Next slide. So you can see actually this is the primary result. No bleed were detected in 35%, so great job by the operator. Next slide. Level 1 was detected in 33%. Next slide. Level 2 was detected in 25%. And level 3 was detected in 7%. So up to 65% of the patient had some sort of a bleeding. And what is important in this slide is when you look at the timing of the bleed detection, so 30%, approximately a third of the bleed occurred during the procedure, but up to 70% occur after the procedure outside the operating room. So it's very important. It's not only the procedure, and most of the operator, when we're done, we're very excited, very proud of ourselves. And then bleed occurred 2 to 3 to 4 hours after. So that's one of the most important finding. Next slide. Next slide. Yeah. So this is some findings about the core lab, the CT scan. When we did the CT scan, 7% had completely normal CT after the procedure. Approximately 60% had some sort of infiltration at the level of the large sheet, and 36.7% had hematoma, and we had no retro actually in this population. And we can talk about that. When we look at the primary endpoint, remember, I want to remind everyone the primary endpoint was the Cohen-Kappa, which is actually the level of agreement, the strength of the agreement between the finding by the early bird, the bleed detection, and the CT scan was 0.84, which actually is almost perfect and is the strongest level of agreement you can find. And if you can go to the next breakdown of this primary endpoint, we had almost 100% of specificity for level 1, 2, and 3, with a very good, strong Cohen-Kappa for all the level. So we met the primary endpoint of the study with very high marks. Next slide. So importantly, what was the action of the clinician when the early bird notified the operator or the clinician of a bleed? Most of them increase the level of clinical surveillance, examine the groin, and notify the doctor. Manual compression was used also in 22%. Some occur when it occurred during the procedure. A crossover balloon technique was done to tamponade the bleeds. Transfusion was done, FemStop was applied, and reversal anticoagulation. So the important thing is you notify the medical personnel very early so you can take the appropriate action and mitigate the bleed. Next slide. So I'm going to show 2 or 3 case example of real life experience. This is a case, 73 years old female, was pretty obese, a BMI of 40. She had severe AS and she was very sick, as all the TAVR patients we do. She was on chronic steroid use. She was on AFib, on NOAC. She had a AAA, and she has very small vessel. As you can see, the mean diameter was approximately 5 on the right and 6 on the left. So very small vessel and borderline on this patient on steroids. Next slide. So the plan was to do a TAVR from the right femoral artery with the Evolut Pro 29, so 16 French sheet. The right femoral vein was used next to the big sheet, the 6 French, and we did a crossover from the left legs to inject using an 018 wire. So the large sheet and the Serranas was on the right groin with a small sheet on the left. Next slide. This is the core valve deployment. It was a very nice deployment. Please take note that we inserted a temporary pacemaker from the groin from actually the early bird. So it's a functional sheet, like Mehdi says. You can put medication through, some fluid. You can put a pacemaker, a swan, a catheter. You can put any type of catheter. It's a functional sheet. Next slide. Next slide. So this is after the case, and when we remove the system, the TAVR system, as you can see, immediately the Serranas start beeping, a level 1 bleed indicator light up. And actually, at that time, the patient was stable. I decided to use the crossover balloon and to do an injection. And this is where you saw this little perf of the external iliac. Immediately did the balloon tamponade, and actually nothing else happened. So that was the first illustration of early bird capturing a very early bleed from an external iliac laceration, and we capture properly the bleed, and we tamponade properly. Next slide. Yep. And this is, we did a CT scan right after, and I can see actually right at the level of the large bore, there was a beginning of an hematoma. And you can see on the right screen, was some small retro. Kept the early bird in place for approximately 6 to 12 hours with no progression of the bleed, with no need for transfusion. The patient was discharged on day 3. Next slide. And this is, as you can see, the patient was slightly obese. You can see the device in action here. It's still, the large sheet is out, and you can see the device with 1 light, and 6 hours post-procedure show only 1 light. So no progression of light from 1 to 2 or 3, which is very important post-op. So it was stable, which is very reassuring. Next slide. And this is what is this is what the Mehdi baby is to have a signal. As you can see here, this is the signal in the Serrana system during the entire procedure. You can see the bioimpedance start at 40, 45, and then when we remove the sheet, the TAVR system is out. You can see this drop of bioimpedance coincidental to the bleed. And this is where the level 1 light occur, and this is where the crossover balloon technique was done, and then you can see a stabilization of the impedance afterwards. So obviously this is the rationale of this system is to provide you a signal same as a telemetry on EKG, and really having a telemetry of the abdomen to map the bleeding. As you can see here, we capture the bleed with a drop of the signal, which is a bleed signature for Serranas, and then you really stabilize the bleed. Next slide. As you can see here, this is this bleed signature of early bird bleed signal. You can see this drop of bioimpedance. Next slide. So this is a second case. This is a same concept. 85 years old, very frail, BMI is 19, very small vessel, and you can see on the bottom right circumferential calcium. There's calcium everywhere. The vessel were between 4 and 5 millimeter, which is a little bit borderline for TAVR, where we need 5.5, and a very high bifurcation. Next slide. So in this case, we elected to do perform this new technology called Shockwave. I'm sure you already know about this great technology. So the goal was to do a TAVR from the right side, to do a prophylactic crossover technique from the other side, use the Shockwave, 7 French lithotripsy device on the right external iliac and common iliac, and with a safety net of Serranas in the right femoral vein. Next slide. So you can go back one slide actually just to demonstrate. Actually, we did a TAVR and TAVR went very well. We removed the sheet. We did a crossover just to make sure that the perclose was well deployed. We took an angiogram and there were no bleed at all. It was a very good result, as you can see the completion angiogram on the right. It's a very good result with no perforation and no dissection. And next slide, and that was confirmed by the Serrana system with no light at all. So this is the early bird in action. And you can see no bleeding, no light. And actually, we discharged the patient on the next day, and no bleed progression was seen for 4 hours post procedure. So we remove everything. Next slide. That's going to be the last case, actually. So it was a 64-year-old male in shock, actually. So it's hard to appreciate, but there's 3-vessel disease with left main involvement. So I did an urgent Impella. The EF was 25%. The patient has severe functional MR. So I put the Impella and open all the vessels. Next slide. So what I like to do in these cases, and we know in urgency situation, the Impella insertion or the large bore access could not be always optimal. So what I did is I get the arterial access, put the Impella sheet in on the left, and put an early bird next to it, 8 French, where I put a swan to monitor the hemodynamic of the patient. So we have an early bird in the left groin, in the femoral vein, with a swan, and then the large Impella sheet next to it in the left artery. Next slide. The case by itself went very well. We opened up all the vessel. Next slide. This is the Impella. Unfortunately, like it happened often, we had ischemic leg on the left side, so we had to did antegrade stick lower and do an external bypass. You can do the next slide. So it's important to see here, and this is a little bit of a complicated situation, but on the left panel, you have the Impella in place with the early bird in the vein, okay, with a swan. The early bird is not activated. I kept it not activated because I knew that this patient will need the Impella for a couple of days. And right now the battery life of the Serranas is 12 hours. So I didn't activate the Serranas, the early bird system. I had to do a bypass, as you can see from the right femoral artery. I did a bypass to the perfusion catheter on the left groin, and with the swan in place for the Serranas. Next slide. The patient evolved favorably, thankfully. And then, like I do all the time, I bring back the patient into cath lab for the Impella removal a couple of days after, and I remove the Impella. And as you can see on the next slide, it was a little bit complicated. So I really like this indication for early bird to do an Impella removal under birdwatch, because you can see, if you're not in the cath lab like this case, you can see what happened if you have a bleed. And actually in this case, there's no bleed initially, but there was a very, very tight stenose at the perclose level. And actually I decided to balloon, probably a little bit too big, and this is where we had a big perf of the SFA. So I had a balloon, so I tamponed the balloon, and I called the vascular surgeon who did his magic as usual. And actually the interesting finding is the early bird was there, initially captured the initial bleed, and then I had to change the early bird to put a second one for the post-op monitoring. And you can see on the next slide, you had a very nice correlation between the bleeding. One light occur when the groin started to bleed a little bit. So just to illustrate that In the animal study, one light came when you have approximately 30 cc of blood accumulation. So that's illustrate that is a really early detection of bleeding for the first light. And when there's a progression, obviously there's more blood. 2 light was around 80 cc volume, and third light was around 150 cc volume. So that gives you a range of volume of blood. It's still early, give you the chance to intervene earlier and mitigate the complication. So I'm going to finish with one figure. Next slide. I also use this device, the Early Bird, with novel closure device. This is the Manta closure device, which is a sort of a big angioseal for large bore catheter. That was a great cases, and I like to monitor the Manta because sometimes there's a lot of bleed with it. There's late bleed, late failure. So I think it's a great safety net for Manta who can have delay failure. So actually, before Bart, I'm gonna summarize what could be the potential use in my practice. Important to say that it could be a venous sheet or an arterial sheet and go in any vessel. I find it very useful for very risky patient, and that's go from advanced age, female, frail, or obese. When a patient has a renal failure with a platelet not being very good. When there's PVD, obviously it's very frequent when we push the limits. When you have small and tortuous vessel, when you have calcium in shock setting, these are all where you have suboptimal access or closure result where Early Bird can be very, very useful. Obviously large bore, when you have more than 10 French is useful. When you have a sheet to vessel ratio more than 1, meaning that when you take a sheet that is too big for the vessel, I think it's going to be useful. Sometimes we do a stick and it's very high in the retro above the ligament. So I think that's going to be useful in this situation. When the crossover balloon technique is not possible, Bart will have a great case. I think that's also a great indication. And in the setting where we have lytic or strong anticoagulation on board, such as neuro, and when you have a stroke or STEMI after thrombolysis, I think that's patient at high risk for bleeding. When I use shockwave, it's always a situation where I'm pushing the limit. I like to have a safety net with Early Bird. And we can discuss when in the future when you use the alternative access, especially transcaval, where you have you can have a surround us in the artery and monitoring the abdomen. So I'm going to stop there and pass to Bart now.
So I don't have too many slides, and certainly from the panel members here, I'm the newest person to have tried this device, and I'm looking at it from the vascular surgeon's perspective. So I'm a traditional vascular surgeon. I do both open and endovascular, and I'm the person that both causes bleeds and oftentimes get called to fix the bleeds. The interesting thing is I got started with this device about a month ago, which was in the absolute peak of COVID here in Connecticut. The state was on lockdown. The hospital had shut all elective surgeries down. And in spite of that, I was able to bring a new product in, which was the product we're talking about today. I was able to get trained remotely via FaceTime. The folks at Cerenas were able to train the OR staff, which, as many of you know, working with nurses, they require a lot of in-services, and this was all done remotely, and we've been able to use it on several cases since then. So I'd like to share sort of my perspective as a vascular surgeon, and I'll just start with the first case that I did. So the first case I did was a 76-year-old lady that had an enlarging aortic aneurysm that was juxtarenal. So she could not get a traditional endovascular aneurysm repair. So I was planning to do a fenestrated repair. This requires essentially bilateral 20 French sheath access. So that's an outer diameter of 7.8 millimeters. And I had some concern, as you can see from the yellow arrow pointing to the external iliac on this CAT scan image. There was about a 6 millimeter vessel with some calcium. So I had to get a 7.8 millimeter device up a 6 millimeter vessel. Now, normally we do that routinely. And most of us that do a lot of endovascular procedures with large sheaths are pretty comfortable with such a scenario. However, in my hospital, the ICU was completely full. Every single bed was full of COVID patients intubated and prone. So normally, if I was to do this, in fact, for all cases, I send them to the step-down unit for monitoring for basically bleed. That's the complication that I'd be worried about. But the step-down unit was also full of ventilated patients with COVID. So I have essentially an aneurysm that's enlarging that could rupture, and I have no access to the ICU. And it's under those conditions that I said, why don't we put in the early bleed detection sheath and would just skip the ICU altogether and send them up to the regular floor. Now, in normal times, no hospital would allow me to ever do that. But these are clearly not normal times, and that's exactly what I did. So if you look on the left, some of you are familiar with fenestrated cases. This is my intraoperative procedure. And you can see that there are two 20 French sheaths placed in the groins, bilateral common femoral access. This is done percutaneously without a cut down. The yellow circle is then zoomed up, and on the right-hand side, you can see the sheath on the left common femoral artery, which has the labels, the yellow labels, is up into the tip. The arterial 20 French sheath is in the common iliac artery, and then labeled right beside it in the vein for bleed monitoring is the 6 French early bird bleed monitoring device. So this was done intra-procedurally, and this is what it looked like. So percutaneous access, you can see 20 French sheaths on both sides. On the patient's right side, there's a 20 French sheath, and in that sheath, 2 or 3 other sheaths. That's not the side I was concerned about. I was concerned about the left side, and you can see the yellow circle zoomed up on the right-hand side. You can see a venous early bird bleed detection right next to a 20 French sheaths. So the procedure was performed, and throughout the procedure, there were no lights that lit up, none whatsoever. The patient then went to the recovery room and was there for about 6 hours. And you can see that this is a picture of that patient's early bird indicator, and you can see 1 light. And I knew that 1 light corresponded with about 30 to 40 cc's of blood. The patient was hemodynamically stable. This provided the confidence I needed to avoid the ICU. We sent the patient up to the floor, waited a few more hours. Everything was fine, and we pulled out that sheath. And that patient went home the next day. They avoided an ICU stay. So this got me to thinking that, there's been a lot of talk in the earlier presentations that bleeds cost money, and that's true. And I think that the number came out as a bleed cost an average of $18,000 in incremental cost. But even if they don't bleed, like this patient, monitoring for bleeds costs money. So every patient that we're concerned about bleeding, which is every large bore access in a small vessel, goes to the step-down unit with a high cost. My hospital has become comfortable now using this and sending them to the floor, at least in this time when all the ICU beds are completely full. So I started thinking about other options. And we have 11 office-based labs, and we do thousands of arterial procedures in our office-based labs outside the hospital. My group does. We're about 26 vascular surgeons in Connecticut and Rhode Island. And we cannot tolerate a bleed in the office-based setting. First of all, there's significant reputational risk because there's a concern that if this is not done in the hospital, is there a safety issue? Which there's not, but that concern is out there. So if there is a bleed, we have less ability to fix it. We certainly cannot cut down on the common femoral artery and fix it like we might in the hospital. And there's a time that if we have a bleed, we have to transfer these patients to the hospital to fix, which can cost time with complications. So you can see on this angiogram on the left, this is a patient that I did in the office-based lab, and you can certainly see there's no contrast there, and there's a lot of calcium. So I use this as the working sheath, monitored for bleed during the procedure in the office-based lab. Everything was fine. No lights went out. Did my tibial work. The patient did well and went home about 4 hours later. Clearly, there's an issue regarding cost of this device in that setting, but this is an area that I think could be explored. And one last area, which I'll sort of finish with, is lysis cases. So we do a lot of lysis as vascular surgeons, and I know cardiologists and interventional radiologists do as well. I'm talking about DVT cases and pulmonary emboli cases. And these patients, the main complication, as most people on this call know, is bleeding. And most of the bleeding, when it happens, is at the access site. And for that reason, most patients spend 24 to 48 hours in an ICU for no other reason but to monitor them for bleeding. And since this COVID crisis has happened and the ICU is full, we've done several venous thrombolysis cases using the bleed detection sheath as a working sheath and as a bleed detector, and have avoided the ICU altogether. So these are just things that we can talk about in the discussion afterwards. I'm happy to be part of this, and that's the end of my talk.
Thank you, Bart. Appreciate it. Thanks all for taking the time to review your cases. I think it's been very insightful. As just a reminder for folks that are attending, you can submit questions through this web portal. Just scroll down and submit it, and we'll try to get through them. We don't have any questions thus far, but I think just to kind of continue on to what you were mentioning, Bart, as well as Dr. Genro, as well as just regarding the integration into the workflow of the device to kind of minimize transport to the CCU. Is this something, is this more of a concern just now, just because of obviously what's being stressed within the health systems, and how you see this technology can be, possibly positioned to support, quicker turnaround, just in terms of confidence?
So this is Bart, and I'll take the first pass at that. There's no doubt that we've been able to do some things in the hospital systems that we never would have been able to do with such rapidity due to the stress and the utilization of ICU resources. But that doesn't mean that this may not become the new norm. I think once it becomes, really validated and people become quite comfortable with the detection of this, and the nurses become trained, then I think there can be an economic and resource utilization argument made for using this technology to avoid stressing the resources of a higher monitored system like the ICU. I think this is early on, but there's clearly a path for this going forward.
I will agree with that. I will say that with this COVID business, we start to be very, very efficient, and resource utilization is key. We started to do TAVR with same-day discharge, and we admit the patient early in the morning. We do the procedure, and if you want to do that safely, you can do that, but you need to make sure to have a safety net to capture potential bleeds that will occur later. And I think in terms of patient disposition in your recovery room, I think that's where early bird could be useful to decipher between patient. If there's no bleed at all, could be potentially sent home the same day later in the afternoon, or if you have small bleed or progression of a bleed, then sent to the floor, or if there's evidence of potentially bleeding, to the ICU. So I fully agree that one of the key point with early bird is patient disposition, and then we can talk also about patient satisfaction, because when you I'm very particular with my groin. Well, I really like the groin of my patient to be perfect. So I think this is a tool that can ensure that you capture a bleed early, and that you increase patient satisfaction also, and keep your reputation. So I think there's for sure an advantage for resource utilization and reputation.
Great. Well, we've got our first question. The question is, and I'll direct it to you, Dr. Genro. What determines when you remove the early bird, and how? Any certain act?
Yeah, so that's a good question. So first of all, in medicine, there's no black and white. It's like a continuum. I will say that um, I give myself 4 hours after a TAVR. So first of all, nobody walk or run within 4 hours of a with a large bore procedure. So I keep the venous sheet 4 hours. If there's no lights, no alert, I'm comfortable removing the early bird, and the patient can ambulate 1 hour later. If there's one light, this is where I decide to keep the device for 2 hours more, and then see actually if there's progression. If there's no progression, I'm comfortable removing the device. If there's progression, this is where I keep an eye on the patient. And this is a nice graph. Like I said, if there's a progression to level 3, this is where I question myself if I should continue to investigate with imaging, look at the hemoglobin, and maybe send for imaging. So this is not prescriptive. This is really help to support the healthcare staff. But usually when there's a level 1, like we said in the animal study, was correlate with 30 cc of bleed. So this is where you examine the groin, and you just keep an eye on the groin, and you can have a manual compression, but usually it's a very, very small and early bleed. If it progressed rapidly to level 2, this is where you start to be a little bit worried, especially if there's a fast progression from 1, 2, and 3. This is where you should take an action quickly, meaning imaging, and send to the lab for an intervention. So I think that's important. Obviously, when you use it in the lab and you activate the device when you're during the procedure, you have some expected bleeding. So if you're about to remove the sheet and do a suture from a perclose and you have one light, it's expected because you just remove the sheet. But if you progress to level 2, this is where you start to be concerned, and you can, if you're in the lab, do a crossover and take a look at what happened. So that's the idea. But I would say, as a recovery device, if you leave this in the cath lab or in your recovery area, I like to leave the device for 2 to 4 hours, and remove the device when there's either no light or no progression for at least 2 hours. So Bart, maybe you can comment on what you think on this from a vascular point of view.
So I basically agree with you. You have to couple the clinical picture, your exam, what their vital signs are, what their symptoms are, and match that to the indication on the early detection device. And you sort of have to, I don't think there's an algorithm, right? You just have to use your judgment. But certainly it gives you a level of confidence when the patient is doing well that you can move them along and move them potentially out of the hospital or to a quicker recovery, which is good for everyone.
I agree. And I think I see this early bird like a telemetry, right? If you recover post revascularization, post STEMI, and you don't have any ectopy, no V's, I think that's great. If you start to have a lot of non-sustained VT or a lot of arrhythmia, this is where you're going to put the patient in the CCU and keep an eye on them, maybe not discharge them. So it's really I really like this to use this analogy of a telemetry of the abdomen, or so I think that has to be used with judgment like any other tool in medicine.
We have
This is
another
Mehdi.
question. Oh, go ahead, Mehdi.
I just one quick question. I think I'm sure many of the participants are wondering, any concerns about having a venous sheath, long-term for a few hours? Do you, any tips? Do you guys use a drip just to prevent clots or things of that nature?
So I will answer first. So in all the case we did, we never had a clot first, but obviously with a sheet in the vein, it could be a concern. So we just put an infusion there, just a line 10 cc per hour, just a KVO to make sure there's irrigation to have a clot formation. And we use this line to give medication if we need. So you have the luxury to have a central line. In terms of the risk of a venous stick, so this is 6 French, 8 French in the vein. We do all our stick to ultrasound. We never saw some so far complication from the Seronas by itself. So I don't think this thing had a complication, a risk for more complication. And actually, if it's thought, it is totally offset by the benefit of capturing a bleed from the big sheath. So that has been my experience with more than 60 or 80 cases. Obviously, after large bore, we keep the patient under back for 4 hours, so that's not going to delay the discharge. And we usually, when we remove the venous sheath, we ambulate the patient after 1 hour. So I think that I didn't experience any risk, any complication with that.
We have a few more questions. I know we're kind of running in towards the end of the hour that I'd like to get to. The first one is, do you have any experience utilizing the early bird with ECMO procedures?
So that's a great question. I did it once in a situation where we had to put a patient on ECMO, and it worked very well. Again, N-Angola 1, but I think this is an extraordinary indication, obviously. But we did one cases with the no bleeds, but I think this is a future great indication.
Thanks. This one may be Mehdi, I might direct it to you. There's a question on how often does the early bird send its impedance monitoring signal? So I guess they're trying to basically ask, and I could answer it as well. I mean, it's a continuous real-time monitoring of the differential change in the impedance that's being sensed by the device. I don't know if you have anything else to add to that, but I guess the question was, again, how often does the early bird send its impedance monitoring signal?
It's the impedance monitoring signal is initiated soon as the sheath is inserted, and it's activated. And after that, as you said, it's continuous. It's important that way because it actually uses the baseline information. The patient becomes a control for themselves as a baseline impedance. The other point to bring in mind is that the output is quite subphysiologic. In other words, the risk of capturing, say, the musculature or the femoral nerve or things of that nature, it's not an issue with this system. But the impedance monitoring is continuous once the sheath has been activated.
Great. We have a couple more. We have one, it was a question to all the docs. What grabbed your attention about the device? And how did you get your labs to buy in and purchase? So
Bart, why don't you take this one first?
Yeah, so I think that there's a couple of things. My interest in the device is that we all want the best outcome for our patients, and the complications that I deal with are mostly bleed related with large bore. So when this device became known to me, I certainly saw an opportunity to improve the care for my patients. I had no issue getting it through the hospital because I sort of made the argument that it's for patient safety, which is hard to argue with, and made the argument that this could avoid an ICU stay in the COVID era, which nobody pushed back on. I'm sure that that's unique because hopefully we're not going to be in this era all the time. That's been my experience.
So, to elude Zafar to the last slide I presented, I sit with my administration, and I told them that a lot of patients, up to 1/3 of the patient that I do TAVR or Impella, or high risk for bleeding. They're either frail, obese, shock status, small vessel, etc., etc. So when you start to look at the cost of a bleeding, the length of stay of a bleeding, and the mitigation with the early bird of bleeds, that's become very a no-brainer. So that's the way to do it, is really to target the patient that will benefit the most, capture the bleed and decrease the cost, and increase patient satisfaction and safety. So.
Great, that's very helpful. No, thanks. I think there are questions on how to present the technology, and I think not just with the case presentations, but the idea of making, improving efficiencies is an interesting one that we're going to better learn as the technology comes on board. There's one other last question. I think it's pretty early, and I'll preempt it a little bit too, but it's Dr. Moose, it's related to kind of your position of where the device could possibly play in the office-based labs. So I guess the question was pretty directed, and how do the economics work in the OBL? I would say it's early, right? I think we'll have to understand it, but I think to your presentation, and you can kind of reinforce, where you see the value of having kind of this early bleed detection, fixated within the OBL. The economics, I think, is still something to be determined, but I don't know if you have anything to comment on that.
Well, that could be an hour-long discussion around the economics of the OBL. Yeah, it's early, right? I mean, let's be real. I'm sure that the people from the company side of things here are selling it at a price to the hospital that probably would not make economic sense in an OBL. But that's how everything starts, right? So things will be modified. Protocols can be driven to select high-risk people. The cost associated with a bleed is very dramatic, even more dramatic in an OBL, I believe. And so there's a lot of moving parts to answer that question. And I think it's to be determined.
Great. And we'll learn. And I think, as we evaluate its position, whether it's, in a hospital versus within the OBL, I think, we'll react to it as the market deems it. But I think the idea of positioning it, as you've mentioned, as a way of mitigating potentially, bleeds that then have to be intervened in the hospital setting, there's still an economic story that can be cultivated. So thank you. We don't have any other questions. We're actually at the hour. I think we want to respect everyone's time. Again, thanks all for, first of all, the speakers to take their Saturdays to be able to present on this very interesting topic, and obviously to you all logging in. Hope you all have a wonderful weekend. If there's any questions, please refer to your local representative. We'll be in touch. But again, thank you so much for logging on to the webinar, and have a wonderful rest of the weekend. Take care.
Thank you.
Thank you.
Thank you.